Good evening, everyone, and welcome to this Support for Doctors Returning to Work in the Pandemic Knowledge Refresher. My name's Dr. Lizy Townshend, and I'm very pleased to introduce you tonight to Dr. Maheshi Ramasamy, who is a consultant physician specialising in infectious disease at Oxford University Hospitals. She's also Honorary Senior Clinical Lecturer at the University of Oxford and Principal Investigator at the Oxford Vaccine Group, where she leads on adult clinical vaccine trials, and her research interest is in adaptive immune responses to viruses, which I'm sure is going to be very, very relevant as she talks to us tonight about management of COVID-19. Good evening, Dr. Ramasamy.
Hello, thanks for that. Thanks for the introduction. I'm just going to... Hello, everyone. I'm just about to share my screen. Just bear with me.
Perfect.
Okay, grand. Can everybody see me?
Yes, thank you very much.
Okay, fantastic. Thank you. So what I'm going to do is just give you a very broad overview of some of the practical issues to consider when you're managing patients with COVID that you will come across on the ward. I think it's fair to say that this has been a very challenging time for all of us learning about this new disease that didn't really exist until a few months ago. I know many of you will be coming from quite different backgrounds to managing COVID patients, and that can be quite scary. But just to reassure you that actually much of this is just common sense, and you already have lots of skills and experience in managing respiratory syndromes like flu and pneumonia, which are directly applicable to COVID. So there are a few pattern recognition things about COVID, but otherwise it's just common sense. So this is what I'm going to cover in the course of this talk, a little bit about the natural history of the disease, infection prevention and control, and then a couple of specific scenarios. So I wouldn't be an ID doc if I didn't show you a picture of COVID. As I'm sure many of you know, it's a single-stranded RNA virus. It has a lipid membrane which it acquires as it buds out from host cells, and this is why it's so amenable to simple soap and water, which dissolves the lipid membrane. It's very similar to other pandemic causing epidemic causing coronaviruses, in particular SARS and MERS, with some differences in infectivity and mortality rates. Just a few things to draw out. One is the spike protein here, an outer membrane glycoprotein, which is involved in binding onto host receptors, which are ACE2 receptors found in upper respiratory tract epithelium. Despite being an RNA virus and therefore usually quite prone to mutation and acquiring sequence errors, actually there appears to have been relatively little variation in the genotype of the virus over the course of the pandemics over the last few months. So the current Public Health England case definition for us as hospital doctors relates to patients with COVID who require admission to hospital for at least one overnight stay. And so the requirement is that they have a clinical syndrome compatible with lower respiratory tract infection, so either clinical changes or radiological evidence of lower respiratory tract disease, or ARDS, or influenza-like symptoms, which include a fever, a persistent cough, which is defined by PHE as coughing quite a lot over an hour, or 3 coughing episodes over a 24-hour period, or worsening of a pre-existing persistent cough, as well as a couple of other symptoms: nasal congestion, breathlessness, and sore throat. I have to say this definition is pretty narrow, and there are lots of there's emerging data that there are other symptoms which might feed into this case definition, such as anosmia, diarrhea, and particularly in frail elderly patients, we see quite a lot of delirium as a presenting symptom. However, if the case definition is met, then patients need to be isolated, sampled, and tested appropriately. So as with many clinical conditions, the diagnosis is all in the history. So it's really important to identify exactly when their symptoms started. And that's important to judge exactly where in the natural evolution of the disease the patient is, and also to guide advice about self-isolation for them and their family in the future. It's useful to get a history of any unwell contacts, though of course you will be familiar with the idea that there's probably quite a large pool of people who have asymptomatic infection. We've already talked about some of the symptoms that you might ask about. Comorbidity is really important. It guides whether or not it guides your decision making around prognosis and treatment escalation. And we know that in the data that we've seen so far from China and in Europe, and indeed even here in the UK, that there are worse outcomes, particularly with chronic respiratory and cardiac conditions. I find it quite useful to get an idea of their exercise tolerance at baseline. It provides the basis for making decisions about treatment escalation. And I usually ask a question like, how far can you walk on a good day when you're normally well? And that's quite a good judge of physical fitness. It's quite useful to ask about who's at home with them, mainly when it comes to thinking about discharge planning in the future. Are they going to be able to manage at home in the context of their current illness when it's time for them to go home? Examining patients is quite difficult, and it's particularly when you're wearing full PPE, it's quite awkward and cumbersome. And there really aren't very many good specific signs of COVID on examination, really. It's important to ensure that there's no other cause for their symptoms, such as heart failure, for example. A couple of things that I found useful are hypoxia, so looking for hypoxia. And this can be pretty asymptomatic. So patients can be sat in front of you talking to you without particular sort of work of breathing, and they have saturations of 92%, which is clearly not normal in an otherwise fit and healthy person. So hypoxia is a useful marker of severity, and also an important thing to keep an eye on because they can deteriorate very, very quickly. I think the only real thing that I can pick out in terms of examination of the lungs is that they tend to have dry bilateral crepitations. They sound more like sort of almost fibrotic as opposed to the wet crepitations you get with pneumonia or with heart failure. But generally the examination is pretty non-specific. And you have to be pragmatic about examining the patient in a way that means you don't expose yourself to the patient's coughing or airborne droplets, and also in a way that keeps that you maintain your hygiene when you're examining, that you don't contaminate your clothes or your stethoscope, for example. The investigations that you perform for these patients is as you'd expect, so the usual sets of bloods, etc. A couple of useful things to pick up on in bloods is a relative lymphopenia that you see on the full blood count. We've often seen patients with a mild ALT derangement, so an ALT of between about 50 and 80. And of course, as normal, you do a clotting and a glucose as a screen when patients come in. The first few patients that we admitted about 4 or 5 weeks ago now, I was routinely doing D-dimers and troponins on these patients, and this is because there's evidence coming out of China that a raised D-dimer and a raised troponin are specifically associated with poorer clinical outcomes. It's quite important if you're doing this to sort of not act on a raised D-dimer and look for a P unless there's another clinical pointer that suggests that they have a thromboembolic disease. And similarly, if you've got a raised troponin but they've got no chest pain and a normal ECG, you shouldn't be going down the end-STEMI pathway. More recently, there's a suggestion that LDH might be a useful marker in scoring systems of disease severity. But again, the panel of bloods that you do will depend a little bit on your local guidelines. Of course, don't forget to do blood cultures, particularly if they're febrile. You don't want to miss an alternative cause of fever, such as a bacterial pneumonia or a Staph aureus bacteremia. So don't stop looking for other causes. It's important not to be too blinkered by the potential diagnosis of COVID-19. And then, of course, it's important to take an upper respiratory swab, which I'll talk about in more detail shortly. From a chest X-ray point of view, the most consistent findings in patients with COVID are of bilateral ground glass changes. They tend to be quite peripheral. They tend to affect mostly the mid and lower zones. And as you can see here on the left, they start off with just sort of relatively minor changes. And then as patients become more sick, this patient is on ITU and intubated, these ground glass changes can progress to frank consolidation. A couple of caveats. Effusions are rare, but are sometimes seen in severe disease. Fibrosis, lymphadenopathy, and non-peripheral changes are rare in COVID-19. Most patients don't require a CT, and it's quite clear from the chest X-ray what the diagnosis is. But if they do have a CT, again, you'll see predominantly ground glass changes on CT. Things on CT that would suggest an alternative etiology would be things like specific localized lobar changes instead of bilateral changes. Cavitation doesn't really fit with COVID-19, and the trine bud nodularity is also unusual in COVID. So I'm now going to show you a video developed by our infection prevention and control team about how to take a respiratory swab. So obviously you need to wear appropriate PPE and use the correct swab. So what you're seeing here is a viral PCR swab. This is different from the standard bacterial MCNS swab that has charcoal in the collection tube. This has viral transport medium, so it'll be a liquid in the bottom of the tube. So once you've got the sort of cotton bund end of the swab, take a really good sweep of the junction between the hard and the soft palate. If they gag, you've done it right. We then use the same swab to sample the nostril, and I think in that video actually she didn't poke the swab in quite far enough. It should be a little bit uncomfortable. And that's it, so pretty straightforward. I will say that the likelihood of getting a positive PCR result depends partly on how well you've taken the swab. We know that the sensitivity of upper respiratory tract swabs is less than lower respiratory samples. So, for example, bronchoalveolar lavage specimens on intubated patients on ITU have a much higher positive yield than upper respiratory tract swabs. But obviously, that's not possible for all patients. And also, depending on the lab that processes the sample, the assay sensitivity will vary from lab to lab. So it's important to remember that a negative swab doesn't mean that they don't have COVID. So with that in mind, patients can be divided into several clinical categories. Either they have confirmed COVID-19, so they have a positive PCR on a respiratory swab, upper or lower respiratory swab, or they can have probable COVID or COVID syndrome. So they may have a negative PCR swab, but they have a compatible clinical story. So they have cough, fever, compatible radiology, so bilateral ground glass infiltrates, and nothing else that would be an alternative diagnosis. So, for example, they don't have heart failure. The trickier group are the possible COVIDs. So these often present with more unusual symptoms, so things like delirium, sometimes with diarrhea, and there's no clear diagnosis, alternative diagnosis to explain their symptoms. And this group of patients, you might want to get a bit of expert help because you need to make decisions about whether or not to cohort them with confirmed or probable COVIDs, and you also need to make a decision about whether or not you re-swab them or do alternative imaging, so for example, a CT. So think carefully about how you might get some extra help to make those decisions. One of the things that has become quite clear about COVID is that it usually presents as a sort of biphasic disease. So patients present here on day one with a bit of fever and a bit of cough, and many of them will improve over time, and you'll never see them again. But then some of them, a proportion of them, will decline quite suddenly around day 7 to day 10. And I have to say, it's really hard to predict which patients are going to deteriorate. Over the last few weeks, I've seen 90-year-olds with minimal symptoms who have got home very safely with no concerns at all. And then equally, I've seen fit 50-year-olds who swim a kilometre several times a week, who decline very quickly over the course of a couple of hours, again, usually about day 7 into their symptoms, and develop ARDS and end up on ITU. So there are clearly host factors in the sort of response to COVID-19, which we don't really understand and haven't really identified as yet. But that can make it difficult for you when you're stuck in A&E and you're seeing people in this part of the disease presentation, so early on, and it's hard to make a decision about whether or not they're going to turn into this participant here down on day 7, patient, sorry, here on day 7 or day 10. I think when you're confronted with a patient in front of you, you need to make a decision to admit or not based on how they look at that moment in time. So are they hypoxic? Are they not managing at home? And that should drive your decision to admit. You certainly can't admit relatively well people and then observe them to see if they fall off their perch at day 7 to 10. Our hospitals would fill up really quite quickly if that were the case. So there is a little bit of a sort of risky discharge that you have to take if you see a patient at the start of their illness, and you need to provide them with the appropriate safety netting, make sure they've got someone at home who can look after them and they know how to seek help if they do deteriorate. Once you've made the decision to admit a patient with confirmed or probable COVID, they need to be isolated or cohorted, and your individual trusts will have specific guidelines and criteria for this that I suggest you become familiar with. It's worthwhile thinking about empiric antibiotics, and I'll talk about that in a little bit more detail. I've included VT prophylaxis as part of our standard initial management, which of course it should be on every patient. There is some increasing observational data that suggests there's an increased risk of venous thromboembolism in COVID patients. The mechanism for this isn't clear, whether it's a direct sort of DIC type effect due to the virus or whether it's just due to systemic inflammation and profound immobility. But currently, there is no evidence for formal anticoagulation with treatment dose anticoagulants without a clear diagnosis of VTE, and there is also no diagnosis, no evidence for giving patients who are discharged prophylactic anticoagulation. It's really important to have a clear resuscitation plan and a treatment escalation plan made on admission, and I'll talk about this in a bit more detail. I'm not going to talk too much about oxygen therapy because I know Tom and Gareth will be discussing that shortly, but just to say that, to reiterate that you need to keep a really careful eye on these patients' oxygen saturations, and I aim for oxygen sats above 92 to 94 with a simple mask, or if they're CO2 retainers, then 88 to 92% with the Venturi, and very careful observation of their sats during the course of their admission. individually, you will find that your trust will have a local policy about when to escalate patients who are becoming hypoxic to critical care or for non-invasive ventilation. For example, in Oxford, we have a policy that patients who require more than 8 litres of oxygen or are on 40% biventuary need to be discussed and considered for escalation. So I'm going to talk very briefly about antibiotics. As an ID doc, I normally hate people prescribing antibiotics unless there is clear evidence of bacterial infection. But I recognise that it's quite difficult to be certain that superadded bacterial infection doesn't contribute to that sort of sudden respiratory decline that you see between day 7 and day 10. And of course, we do treat patients, for example, with flu, who come in with a sort of second worsening of their infection with antibiotics to cover bacterial superinfection. Do think about whether the patient in front of you really needs it, though. So if they've got a clear chest, a normal chest X-ray, and their SATs are fine, I probably wouldn't give them antibiotics. Now, for most community-acquired pneumonias, all of us would use a simple penicillin, amoxicillin, for example, which would normally be a 3 times a day antibiotic. For COVID-19 patients who are in hospital, it's important to try and minimise the number of direct face-to-face interactions that nursing staff have to go through with each patient. So we try to use once daily agents as best we can. So for example, doxycycline, azithromycin, or moxifloxacin. Now, all of these are antibiotics that we would normally use to cover atypical pneumonias, but I just want to stress that that's not why they're using them here. Atypical agents like Legionella or Mycoplasma are not major causes of secondary bacterial pneumonias. We're using these antibiotics just because of their pharmacokinetics that allow once daily dosing. Some of these drugs may be more unfamiliar to you, so moxifloxacin and azithromycin aren't commonly used, so do check for drug interactions and be aware, for example, of things like moxifloxacin prolonging the QT interval, so you might want to make sure they're not on any other drugs that might do the same. If they need IVs, then a good go-to once daily IV antibiotic is ceftriaxone. As with all antimicrobials, good stewardship is important, so use a shorter course as possible and do monitor patients for antibiotic-related adverse events. Related to that, it's quite important to go through the patient's drug chart and rationalise what they're on. Particularly older patients are, come into hospital on a whole host of medications. Not all of them are required every day. And again, the rationale here is that you want to minimise the number of times a nurse has to go into that patient's bed space to see them. So hold off any unnecessary medications like folic acid, if that's not going to make a difference in the short term, and try and rearrange timing so that all the drugs are given at the same time. So for example, things like low molecular weight heparin, we often give those at 6 o'clock in the evening, but if they're having an antibiotic at 8 in the morning, there's no reason why their Fragmin can't also be given at that time, just to save nursing time and interactions. Just a couple of other things to mention. There's been a lot of anxiety about non-steroidals. There have been some observational reports that suggest that patients on ibuprofen are more susceptible to COVID or might have worse COVID disease. The scientific basis of that is that the anti-inflammatory effects of non-steroidals might hinder antigen presentation and a good immune response. However, there is no clear evidence that this is the case, but the MHRA has issued guidance to suggest that paracetamol should be used in preference to ibuprofen, but if somebody's already established on ibuprofen, for example, for rheumatoid arthritis, then that shouldn't be stopped. There's also been some concern about the use of ACE inhibitors or angiotensin receptor blockers. And this derives from the theoretical risk that using these agents might upregulate the ACE2 receptors in the respiratory epithelium and therefore kind of worsen your likelihood of developing severe disease because you have a higher viral load. Again, there is no evidence that this is the case clinically, and the European Society for Cardiology position statement says that we should continue using these drugs unless you would discontinue them for clinical reasons such as hypotension or acute renal failure. As physicians, it's quite frustrating not to know what to offer patients, not to know what the treatment is for COVID-19, and everybody feels quite driven to be able to do something for the patient in front of you. There have been all sorts of kind of postulated theories about drugs that could be used, lots of random case reports and observational data about all sorts of drugs, IL-6 and anti-IL-6 monoclonal antibodies. You've probably all had the WhatsApp about tea curing COVID-19, but it's really important to remember that we need to practice evidence-based medicine. We wouldn't experiment with a patient with breast cancer with a drug that we're not familiar with. And the same principle applies here for COVID. We don't know what the best treatment is, and the safest option is to enroll the patient in a good quality randomized controlled trial to develop that evidence base that we need going forward. There are 3 nationally prioritized RCTs supported by NHS England and the devolved regions. The one of most relevance to us as hospital physicians is Recovery. And this is a trial across the UK and Ireland. I think there are about 160 trial sites, and they've randomised about 4,000 patients to this. Patients are randomised to standard care, so fluids or IV antibiotics, for example, or standard care plus one of either hydroxychloroquine, which has some in vitro data against SARS and has some promising early morbidity data coming out of China and France. Dexamethasone is the second arm, and the idea is that the anti-inflammatory effect will dampen down the cytokine storm that's thought to underlie the second dip of disease that we see at day 7 to 10. The third agent is Kaletra, which is an HIV drug, lopinavir-ritonavir combination, and that's got some efficacy in animal studies of MERS. There's a small study in ITU patients in Italy, which doesn't actually show any evidence of benefit in mortality, but it does have some benefit in terms of ITU stay and time to discharge. And the final randomized arm is azithromycin, which is postulated to have some anti-inflammatory effect. So I'd encourage you all to visit the website for Recovery, which I've put up on there. Many of your hospitals will be sites for Recovery, and this is a very pragmatic trial. Any clinician can recruit a patient to Recovery. You don't need to be GCP trained or on a delegation log. It's very simple and straightforward to do. As I've already alluded to, patients with COVID can deteriorate really very quickly indeed, and so it's essential to make a consultant or registrar-led decision about treatment escalation plans at admission. You're not waiting for the deterioration. It's challenging because patients can be delirious and confused when they come in. They're often terrified because they've read all the BBC News websites about how many people die with COVID. And often they don't have family with them, so you end up having difficult discussions with the patient behind a mask so they can't see you properly, or with the family on the phone. So it's really hard to have these conversations. But I think it's important to be clear with patients and their families that the decision you make should largely be irrespective of the resources available to deal with it. Is the patient in front of you a good candidate for ITU? And that's the first decision you need to make. There may then be a secondary level of decision making involving the allocation of resources, depending on the position your trust is in. But that first decision is, would they benefit from ITU anyway, regardless of resource allocation. And we know from experience that many frail elderly are unlikely to do well on ITU with community-acquired pneumonias, and COVID is worse than a standard community-acquired pneumonia. To help with making these discussions, NICE has recently released this document to help guide decision making using frailty and comorbidities to kind of create a sort of decision tree. And essentially, if they're not frail, they should be managed aggressively, and if they deteriorate, they go to critical care. If they're more frail, then you make an early decision about whether critical care is or isn't appropriate, and then manage them appropriately. I have to say, I don't really think this flow diagram adds very much to what should be happening anyway to every patient who is admitted, who is acutely unwell, regardless of COVID. But you know, I think we're just not very good at doing this. So having a reminder and a prompt to do this at the beginning of every admission will probably is just good practice. This specific guideline refers to the clinical frailty scale, which I've put up here. So this is a way of categorizing frailty, mental and physical frailty. And patients get various scores according to where they fall along that scale. It's important not to use this in patients who have a long-term disability, such as cerebral palsy, where actually their baseline might be very dependent anyway. You know, they might be wheelchair bound, for example, but that doesn't truly reflect their frailty. You need to make an individualized frailty decision on them and not use this score. Just for the final few slides, I thought I'd run through infection control. This has changed multiple times over the last few weeks, and it's very much a moving target and sometimes has been contradictory. This is the most recent guidelines for all clinical interactions. So for most interactions, you need to wear level 1 PPE, and in fact, this poster itself isn't fully accurate because we should essentially be wearing eye protection for pretty much any clinical interaction. So in A&E, in clinics, on the wards, we should be wearing eye protection if possible. Level 2 PPE is illustrated here, and that's really only required for aerosol generating procedures, which I've listed down the side here. I think as well as knowing how to safely doff and don your PPE, and there will be local training for this, I'm sure, in your trust, and if not, there are lots of good videos that you can find on YouTube about how to safely do this. I would say it's really, really important to be aware of your surroundings when you're examining a patient. So, you know, for example, if you're in a patient bay, there's lots of stuff around there that is potentially contaminated with patient's aerosol droplets. So the curtains, the fabric curtains around the bed space, the patient's tray table, the bedding. Really important to give yourself the space to examine a patient safely. I personally always draw the curtains back when I'm examining a patient because it just gives me a bit more space to maneuver, unless I'm doing, you know, an intimate examination, which is not very often. You can examine most patients' chests or feel their tummies through their clothes and maintain their dignity whilst keeping yourself safe. Be aware of yourself as well. So I'm always paranoid about my arms, which I always feel are quite exposed when I'm examining patients. And when you're sitting somebody forward or they're coughing, you know, your bare arms are exposed. So do make sure you give your arms a good scrub along with your hands when you're washing them at the end of a patient interaction. Tie your hair up into a bun if you can. Don't have a floppy ponytail dangling over the front of your apron. And remember to clean your stethoscope if you've used it to examine the patient. One of the scenarios that I found the most challenging in dealing with COVID has been delirium. In itself, it can be a symptom of COVID syndrome, and it can make looking after a patient really difficult, you know, in terms of keeping yourself safe, but also reducing the risk of cross-infection if they're agitated and confused. So I think, you know, we need to be good at managing delirium, and we need to reduce the risk of it by avoiding common precipitants like urinary retention or pain. You need to try and orient the patient regularly, maintaining good day-night balance. But all these sort of non-pharmacological things can be really difficult in isolation settings, and when you haven't got the staff or the time to do it, and sometimes you just need to think a little bit more imaginatively. We found using YouTube channels with classical music on a loop really soothing, for example, for agitated patients, and also quite good for the doctors and nurses on the wards too. Do maintain good practice as you would normally. So if you're having to restrain a patient, you need to put a deprivation of liberty safeguard document in place, for example. But if you really can't manage with good orientation and sort of a nursing care, then you may need to consider early pharmacological interventions. I found this useful table on the British Geriatric Society about some starting drugs that you could use in the context of COVID, but do be careful about over-sedating elderly patients who already have a respiratory syndrome. The last thing you want is a respiratory arrest. There's emerging evidence that patients with, well, firstly, diabetes is a risk factor for COVID disease because of the immunosuppression associated with it. But there's also evidence coming out of centres such as Leicester and Coventry that patients with COVID have a greater risk of hypoglycemia and DKA, particularly in type 2 diabetics or patients on SGLT2 inhibitors. So Diabetes UK has got some really nice guidelines on the front door management of diabetes. I've included the most relevant table here, which essentially just says that all patients should have glucose measured and ketones if they're diabetic or hypoglycemic. And all patients should have SGLT2 inhibitors and metformin stopped on admission. Sadly, many of our patients that we look after will succumb to COVID. I guess from my personal experience, I'd say people seem to die in two ways. They come in and die very quickly with very minimum symptoms, and actually palliation isn't so much of an issue in those patients because they die so quickly. And the second sort of pattern I've seen are the more elderly, frail patients who linger sometimes for several days. I think dealing with death and COVID is really, really challenging as a physician because you just have so little time to have the difficult conversations that you have with patients and their families. The families can't be present. And frankly, it's a pretty terrifying environment for patients. They feel scared and breathless. We're all surrounding them wearing masks. It's really difficult. The most common symptoms, I would say, are breathlessness, cough, fever, and agitation. And I've put up some pharmacological and non-pharmacological ways of dealing with each of these symptoms. The reality is that in cohorted wards or in isolation settings, some of the non-pharmacological interventions that we would normally use are just not really possible. So, for example, you can't use a fan for breathlessness or for fever as you normally would. The other thing I would say is to consider using syringe drivers early if it becomes clear that a patient is dying. It's quite difficult to go in and see a patient every hour as you normally would in a dying patient, and patients might miss out on PRNs if that were the case. So I think if it becomes clear that they're dying, have a low threshold for starting them on a low dose syringe driver. If they do die, then you can put COVID-19 down as part 1 or part 2 on a death certificate. This does not need to be confirmed by PCR, but we do need to be sure that they have probable COVID or COVID syndrome during their admission. And in themselves, you don't need to refer a COVID death to the coroner, but of course if they had recent surgery or died within 24 hours, then that would need reporting as normal. If your patient gets better, and most of your patients hopefully will, and they need to remain as an inpatient, there are some PHE has guidelines about when you can de-escalate the level 1 PPE required to see these patients, and this might also help for patients to move from a cohorted ward to a non-COVID ward, for example. So this, for step down to occur, patients need to be at least 14 days after a positive PCR test. They need to be getting better, and they need to have been afebrile for at least 48 hours. This guidance is slightly different if patients have severe immunosuppression, so defined by PHE as leukemia, lymphoma, recent bone marrow or solid organ transplant, more than 40 milligrams of steroids a day, or recent anti-TNF-alpha monoclonal antibodies. In this setting, we know that patients actually shed virus or are PCR positive for certainly longer than 14 days, maybe up to about 25 to even 30 days. So in this setting, it would be important to seek specialist advice about de-escalating infection prevention and control, and local protocols for this might vary. It might be that you pragmatically keep infection control precautions going, or if you have sufficient resources, there might be scope for repeat testing until their PCR becomes negative, but that will depend on what you do locally. The guidelines are a little bit different if you're discharging the patient home. They don't need to isolate for quite as long. They don't need infection control for quite as long, and that's because they're going back to their own home and they're not around other vulnerable patients. So as long as they're stable, you can send them home at any point in their illness, along the at any point in their natural history. You don't need to wait to a particular day. They need to self-isolate for only 7 days from their first positive COVID test. If they are immunocompromised or if they had a spell on critical care, then they need to isolate for 14 days. So the advice is slightly different again for healthcare workers who are exposed to COVID-19. So if you inadvertently become exposed to COVID, for example, because you had a breach of PPE, you do not need to self-isolate if you're asymptomatic. However, if you develop symptoms, so fever, breathlessness, cough, etc., then you do need to stop working and inform your local occupational health team, who will advise you how to arrange for screening. Local guidelines will vary from trust to trust, but the PHE guidance is that you can return to work on day 8 after your symptom onset, as long as you remain well and afebrile. So that was a very brief overview of the management of COVID, just based on my experiences over the last month or so. So just to summarise, the elderly and people with particularly cardiac and respiratory chronic illnesses are at particular risk of severe infection. Think carefully about and look for hypoxia, because patients are often asymptomatic with it, and they can deteriorate quite quickly. The sensitivity of the PCR swab varies, and if they have a clinical syndrome compatible with COVID, they can still be managed as COVID disease, even if they have a negative swab. Don't forget to think about other things that people that people can have. So, people will still have strokes, people will still break their hips. They might also have COVID, but don't forget to think about other disease processes. Those other things aren't going to stop happening just because we're in the middle of a pandemic. Be careful about off-piste prescribing, and enroll your patients in good quality clinical trials where you can. And it's really important to be confident with your PPE doffing and donning, and to be absolutely obsessive about good infection control. Thank you.
Thank you so much, Dr. Ramasamy. I really appreciated that really concise whistle-stop tour through that disease, which I can see that we've got a lot of questions on, and I know that the scientific community in general has a lot of questions about coronavirus, so I'm not surprised that there's a lot of questions in our box, and I'm also expecting for that reason that we won't necessarily be able to answer all of them. But if you don't mind, I'll run through a couple. How sensitive is the PCR test, and if it's negative, can you rely on that?
No, I think is the answer. So the sensitivity assay will vary from lab to lab. In our own lab, we're quoting about 90% sensitivity, but the caveat to that is that it has to be a good swab to start with. So if you don't sample properly, you're more likely to get a negative test. And as I've said, the dynamics of viral shedding and PCR positivity will vary from participant to participant. So certainly I've seen people who've been who've had negative swabs both early and quite late on in their clinical history. So I think if they have a history compatible with COVID and they have radiological signs, treat them as if they have COVID. They have probable COVID even if they have a negative PCR.
Thank you. There's also a few questions from people who I think are probably reasonably worried about catching COVID themselves and amongst their families, asking about the uses of vitamins C and D and BCG and whether we should be advocating the use of those.
I think that's really understandable. It's really frightening seeing these patients, some of whom are actually quite fit, become unwell quite so quickly. But unfortunately, there is really no evidence for any of these interventions for vitamins and so on. I think what you can do though is have really good infection control. So be absolutely meticulous in how you wash your hands. I wash my hands right up above my elbow when I'm wearing scrubs to make sure that every bit of exposed skin is washed. Be aware of not touching your face, not touching your mask, having your hair tied up, not having lanyards hanging around, and be aware of what's around you in the bed space when you're examining your patient. I think all of those are much more important in preventing you from getting COVID than vitamin C. Sorry, I think you're muted. I can't hear your last question.
That's right, I am muted. Thank you so much. When we have patients who present with a non-case definition presentation, so for example, they've come in with delirium, are we swabbing those? Are we swabbing people who don't have any symptoms that we might think of for COVID who are coming into hospital?
So that's a good question. I think it's very easy when they have clear textbook COVID symptoms, cough, fever, as described by PHE. And I think this is where clinical judgment comes in. If they haven't got a clear alternative diagnosis, they haven't got a PE, they haven't got a septic arthritis, if in the context of a pandemic, there is going to be a lot of COVID around. So I think if they're presenting with slightly unusual symptoms and you haven't got a good alternative diagnosis, think about doing a swab. I don't think it would be wrong to do a swab in those circumstances. And if you're not sure, ask for senior help, ask your consultant, ask the IDU micro team for their advice.
A couple of questions about the swabs that we're using. There's been some conversation about how far you put the nasal swab in, whether you do one nostril or both, and why we use the same swab for nose and mouth.
So you need to use a viral PCR swab. The exact appearance of the swab will vary from trust to trust. There are lots of different brands of viral PCR swabs out there. In terms of how far to put it up, you want to be sampling at the sort of apex of the nasal cavity. So, not as far, for anyone who's done A&E, not as far as you push in a nasal tampon for a bleed, but, you want to be sampling, that sort of level, fairly high up. That video that I showed you, they were just sampling the nostril, and that's probably not good enough. You use the same swab pragmatically because we don't have enough swabs, and it means that you just have to do one PCR. You're able to detect very low copy numbers of RNA on a swab. So if you get a good sweep in your throat, you're not going to rub that off by then doing a nasal swab.
Thank you. And do you, when you're requesting investigations, we've seen some questions about the testing ferritin levels. Is that something we do?
So I mean, certainly in Oxford, we haven't got a defined set of screening bloods to help define severity. So I talked about troponins, D-dimers, and some people are using LDH. I've also seen papers about ferritin, and I don't think it would be wrong to do that. I guess the caution is that we don't want to be requesting lots of expensive tests, or tests that we then aren't interpreting correctly. So, for example, with TROPS, we don't want to be then starting everybody on NSTEMI treatment in the absence of a compatible clinical syndrome. So I think I would say watch this space, because I'm sure that there will be emerging evidence as to what the best scoring system is to predict disease severity.
Thank you very much, Dr. Ramasamy.
We have added several slides with the audience Q&As that we ran out of time to ask during the live webinar, but our speaker kindly typed answers to.